Good morning, everybody. I wanted to introduce myself. My name is Ramana Moorthy, and I'll be talking to you today. And I want to welcome everybody from all over the world. I hope you guys are dealing with the pandemic as better than we are. And I hope this will soon come to an end so we can, at some point, I can meet many of you in person. Some of you I've met in person probably. But I wanted to welcome you today. So today I wanted to focus a little bit on drug-induced uveitis. This talk also includes a little brief interlude into drug interactions initially, and one specific interaction that I wanted to highlight that is very important for ophthalmologists and uveitis specialists or retina specialists, because we tend to use corticosteroids, and then subsequently talk about some of the more common causes or common associations of drugs and uveitis. Causation is a very difficult thing to determine many times in medicine. We can go by statistical anomalies, and in the case of drug-induced inflammatory disease, though, we use specific criteria that I will discuss with you. These criteria were developed by pharmacologists with a great deal more experience on adverse events than I had many years ago, and I'll discuss that with you. I have no financial disclosures, and we'll start off with a poll question to begin with. And I'll read the question. You'll have 30 seconds to answer. The highest risk and incidence of peptic ulceration occurs with which of the following therapies? A, systemic corticosteroids alone. B, systemic NSAIDs alone. C, systemic NSAIDs combined with systemic corticosteroids. Or D, systemic corticosteroids combined with systemic methotrexate. Which has the highest risk and highest incidence of peptic ulceration? Okay, excellent. So most of you got this right, and I'm going to close this off here. But you're right. The combination of NSAIDs and corticosteroids are substantially put patients at a higher risk for developing peptic ulcerations. And there are many drug interactions that uveitis specialists and general ophthalmologists should be aware of, because we use corticosteroids quite frequently. Of course, most of us use it topically, but many of us do have to use them systemically from time to time for various disease processes. Immunomodulatory therapy and biologics are really kind of relegated to other specialists. I'm going to kind of go back here for just a second. I think this is the slide shows on kind of an auto advance for some reason. But the immunomodulatory therapy has varied mechanisms of action. I won't go through the details of this. Obviously, corticosteroids ultimately inhibit the transcription and translation processes that occur in the cell nucleus. And subsequently, the translation processes are inhibited more, of course, in the cytoplasm of the cells. But there are other agents that we use, like the immunosuppressive medications, that have different effects on the cell cycle, as well as the way that they modulate interleukins and ultimately inhibition of the cell cycle indirectly. So if we look at some of the most important interactions between systemic corticosteroids, by far the greatest problems that we encounter is when we use corticosteroids with systemic and nonsteroidal anti-inflammatory medications. Nonsteroidal anti-inflammatory medications produce a 20-fold increased risk of peptic and gastric ulcers. Originally, the reports came out that people saw hemorrhagic gastritis, hemorrhagic gastric ulcers with the use of IV corticosteroids. But many of these patients had other issues that put them at risk for that. This is from the early reports in the 1970s and 1980s. And so many times when we start oral steroids, we often place patients on medications to reduce the risk of ulceration. We might place patients on PPIs or proton pump inhibitors, or we may place them on H2 blockers prophylactically. But I think that the most important thing is that the NSAIDs produce a much greater risk for the patient and induce the development of gastric and peptic ulcerations much more significantly than steroids alone. So the most important thing is to probably avoid using NSAIDs in combination with corticosteroids. When you use systemic corticosteroids, it's probably, if the patient is on NSAIDs for other reasons, you probably should avoid putting them together. and avoid having them use the NSAIDs while they're on the steroids, if at all possible. And if you, in addition, if they've been on chronic NSAID therapy, you might want to institute PPI, or you might want to institute H2 blockers in association with the internist. There are other things. Many times the induction of hepatic cytochrome P450 system and the metabolism of the medications like anticonvulsants and so forth can change how corticosteroids, how effective they are. So decreased corticosteroids may be seen with anticonvulsants and many different anti-infectives. The anticoagulant effects of warfarin, for example, are increased by corticosteroids because, again, the anticoagulants kind of compete with the cytochrome 3A4 system, which is important for the metabolism of these agents. And corticosteroids are also similarly metabolized by those. So they're competitive, compete for those, for the enzyme activity, and that can alter the metabolism of those medications. I won't bore you with these lists, but you can see that there are many different things that we have to consider. One other thing I would point out is that fluoroquinolone, when used with systemic corticosteroids, appears to increase the risk of developing tendonitis and tendon rupture. But here's the pathophysiology that we see in terms of with corticosteroid-induced enteropathies. The corticosteroids decrease gastric bicarbonate production and decrease mucus production. This is made worse by the NSAIDs, which also have similar effects on mucus synthesis and prostaglandin synthesis. And as a result, there are significant changes that occur in the mucus production and blood flow to intestinal mucosa, compounded by the decrease in bicarbonate production by corticosteroids. And that results in significant cell injury, increased intestinal permeability to bacteria, bile acids, proteolytic enzymes, and toxins, which are normally the mucus and prostaglandin tend to kind of coat and prevent the activity of these proteolytic enzymes, and that is inhibited when you have all of these agents together, the NSAIDs as well as the corticosteroids, and that increases the risk of you developing significant erosion, ulceration, bleeding, protein loss, all those things that would develop in this corticosteroid plus NSAID induced enteropathy. So this is important to keep in mind, and this is one concept that I wanted to kind of go over with you. The other things we won't have to spend too much time on because most of you may not be using these agents. Methotrexate, for example, a commonly used immunomodulatory therapeutic agent for uveitis and chronic uveitic conditions, non-infectious uveitis. Its effects can be altered by antibiotics. Certain antibiotics increase the effects of methotrexate and some decrease these. And many of these are due to a displacement of plasma protein-bound methotrexate in the serum, and some of them are due to inhibition at the level of the renal tubules. Mycophenolate, another commonly used anti-metabolite, again, is an inosine monophosphate dehydrogenase inhibitor, very potent in terms of cell cycle inhibition and prevention of lymphocyte proliferation. And this agent can have multiple different drugs that can actually inhibit its activity. And most of the drugs that you can see here outside of the antivirals appear to reduce the efficacy of mycophenolate, mainly through GI absorption. As you know, that's a very important mechanism by which mycophenolate gets into the body when it's taken orally. And many of the side effects of mycophenolate are gastrointestinal related. So as you can imagine, the GI system is very important in the way that the drug is metabolized, and the bioavailability of this drug is affected when you have these other agents used concomitantly. Azathioprine, again, thiopurine methyltransferase inhibition. This drug also is increased amounts of the effects of azathioprine can be seen when allopurinol is utilized. ACE inhibitors, interestingly, very commonly used. If you give azathioprine with this, you may see severe leukopenia or anemia result from this. And I have seen this happen in patients who inadvertently were on chronic ACE inhibitor therapy for hypertension. Cyclosporine and tacrolimus, a little different. These are dependent on the cytochrome P450 system in the liver for metabolism, and drugs that inhibit or competitively use the P450 system can actually cause cyclosporine levels to be modulated. And you can see the different agents. Many times you'll see these antifungal agents like fluconazole come up very commonly. These agents tend to inhibit cytochrome P450, so they cause significant elevation of cyclosporine levels. So this has appeared on board questions in the past: fluconazole, ketoconazole, and proconazole. Those agents increase cyclosporine levels and increase the significance of the toxicity, nephrotoxicity associated with the drug. Excuse me. I think I apologize. I had some audio that was mixed in here. Alkylating agents, cyclophosphamide, et cetera, these also have a few drugs for which they interact with. And Tacrolimus can interact with rapamycin. We won't go into the details of some of these. These are probably beyond the scope of, because these agents are very rarely used. I can come back and answer specific questions about these drugs if you have them. But these are just informational slides for the most part. There's drug interactions with biologics are very different than chemical drugs, because biologics are high molecular weight molecules. They're complex and heterogeneous. They're strongly dependent on manufacturing processes, and they're difficult to characterize in terms of how do they act, et cetera, in terms of compared to how you characterize chemical drugs. And they may be very sensitive to external conditions, as opposed to a tablet that you take. Biologics have to be stored a specific way, injected a specific way, or given a specific way orally. And they can be potently immunogenic in many cases, whereas chemical drugs typically are not. And so these are obviously differences. And so when we talk about interaction between the biologics versus pharmaceutical agents, we have to think about a very different approach to these. And the route of administration, the absorption, distribution, all of these is very different. And in fact, even the effect of the drugs pharmacokinetically may be very long in duration when we use monoclonal antibodies, for example, compared to chemical medications. Although biologics don't appear to interfere with other systemically traditional pharmacotherapy, systemically administered traditional pharmacotherapy, these interactions are pretty underappreciated. I'm going to go to the next question, and this will kind of segue into the main topic, and I'll spend more time here discussing drugs and uveitis. This question is: drug-induced uveitis should be considered in which of the following scenarios? A, only if the uveitis is bilateral. B, only if other causes of uveitis have been ruled out. C, only if inflammation resolves upon drug discontinuation. And D, only if the inflammation recurs on rechallenge of the drug. So this is a kind of a tough question, and I apologize for that. But my point in asking this question is that when we think about causality, when we think about what is causing uveitis, it's a very difficult question sometimes to answer. A laboratory test may be elevated or may be positive, for example, and we may say, well, this is the possible cause. Probably what we mean to say is this is the possible or probable association, but we have to combine what we see clinically and historically in the patient to ultimately make that diagnosis. For example, if somebody has a Hypopyon uveitis and they are HLA-B27 positive, are we sure that that is the underlying cause of the Hypopyon uveitis? We've, of course, ruled out the possibility of other causes of inflammation. So the point of this question is that only if other causes of uveitis have been specifically ruled out, that is, we have done a uveitis workup on patients, then we can come up with the diagnosis that perhaps this drug or drugs may be the underlying cause of the inflammatory disease. So causality is very important and very difficult potentially to determine. And so that is the reason that I put this question. So other causes of uveitis must be ruled out before you can say, oh, this is drug-induced uveitis. A laboratory workup in uveitis patients is important, as well as a good history and physical, in order to determine what is the underlying cause. So drug-induced uveitis is really kind of based on an accurate history and physical examination. It is a diagnosis of exclusion. that being said, many times the effect of the drug is known. It has been well described, and so we can make and jump and leap to that conclusion. Hey, this is what it is. We know for sure this is what it is. We probably don't need to do it as extensive a laboratory workup that we would otherwise. But we are faced sometimes with situations where this is a new drug and this is an inflammation that we're seeing, and we're worried, hey, is this drug-induced or something else? There, we're going to do a much more extensive laboratory evaluation as well as a much more thorough history and physical, and then ultimately make this diagnosis of drug-induced uveitis by exclusion. Even commonly used drugs are not immunologically benign. This is my daughter, who unfortunately a week before starting college got a severe drug-induced inflammatory reaction and serum sickness as a result of minocycline exposure. She had developed severe transaminase elevation, high fevers, and this very severe rash. And she recovered, but it required systemic corticosteroid therapy. And we were very concerned about her. Obviously, she became very ill. Drug-induced uveitis causation determination is based on multiple criteria. It is based on previous conclusive reports of this reaction. The adverse reaction appears when the drug was administered. It improved when the drug was discontinued. This adverse reaction reappeared when the drug was readministered. And alternative causes other than the drug have been excluded. And the adverse reaction reappears, if the adverse reaction reappears with placebo, well, that tells you that maybe that's not the cause. Toxic concentrations of the drug have been measured. That can help you. Adverse reaction was dose dependent. As the dose escalation results in worsening of the reaction, well, that tells you also that this is a causality. And then finally, and the last two, the adverse reaction to drugs in the same class, other drugs in the same class produce the same event. And then, of course, you have objective evidence to show what these adverse events are. For example, the skin rash that I showed you in the picture, or the fevers, or the transaminase elevation. These criteria were developed by Naranjo back in 1981. These are very forward-looking and extremely important toxicologic principles regarding drug-induced uveitis. Let me go back for just a couple of seconds. Do we know why drugs produce uveitis? We really don't. Some mechanisms, such as direct toxicity, may be playing a role because those toxicity changes induce an imbalance between interleukin-2 and interleukin-17, resulting in free radicals, cytokines, and inflammation. Sometimes the drug itself can induce vasculitis or lupus. For example, the original reports of quinidine and quinine derivatives associated with lupus, or even more recently, infliximab causing sarcoid-like inflammatory, granulomatous inflammatory disease. There are some factors regarding drug-induced uveitis that we don't understand. Why is it that some drugs only cause unilateral uveitis? For example, Rifabutin, or bisphosphonates, or immune checkpoint inhibitors. Why do some agents in the same class cause uveitis, even with rechallenge, and others in the same class do not? For example, etanercept has a much greater risk of inducing de novo inflammation in the eye versus adalimumab, which is less likely to do so. Is causation definite? How do we prove beyond the use of just the criteria? We won't really be able to do that unless we can elucidate the mechanisms of drug-induced uveitis. So causation is something that we have to kind of think hard about. We can say, hey, this is likely the underlying cause, but we might have to kind of back off and in terms of saying definitively the cause. But how can we help ourselves by using those 10 criteria? If we weight some of these criteria, that may help us in terms of making sure that we have a definitive versus probable or possible causes. So this table was developed about 5 or 6 years ago by a group of us looking at those Naranjo criteria and putting a weight on them. So for example, some of these are weighted heavily. For example, if there is a re-challenge and the drug was re-administered and you get the same reaction, well, that's very important because that tells you, yes, causation is likely. And if the, the reaction occurred right after the drug was administered, yes. But if the reaction occurred, alternative causes of the reaction were found, well, then you're less likely, you're going to actually detract from that number. And so we tally up all of this for each drug and then come up with a number. And so that number or cumulative score, if you will determine whether or not there's a definite likelihood, causal likelihood, a probable causal likelihood, possible or doubtful causal likelihood. I hope that makes sense. And this slide does require a little bit of studying. And I'll try to make this slide available to you guys hopefully through CyberSite. And then we can, there are many systemic medications that are associated with uveitis that we'll cover quickly, but some that I want to spend a little bit more time on. And there are also intraocular medications that are associated with uveitis, cidofovir, anti-VEGF agents, and triamcinolone, unpreserved triamcinolone. And of course, topical medications such as brimonidine and metoprolol and prostaglandin analogs have been associated, along with topical cutaneous medicines even have been reported to be associated with inflammation. And finally, we'll spend a little bit of time talking about a little more controversial topic as drug-induced uveitis with vaccinations. The first drug I want to talk about is systemic and intraocular cidofovir. It is a selective inhibitor of viral DNA polymerase and prevents cytomegalovirus replication. It was utilized as a second-line and third-line agent for cytomegalovirus retinitis in the AIDS epidemic era in the 1990s, in the early 1990s. It has a long intracellular half-life, so it was advantageous to use and administer intravenously and intravitreally. Unfortunately, though, there was a significant risk with whether given systemically or intraocularly. This drug appeared to produce non-granulomatous anterior uveitis and hypotony. It also produced severe nephrotoxicity. And the risk factors appear to be that in patients who are HIV positive on protease inhibitors treated with CMV retinitis, who had chronic and recurrent retinitis and who also had immune recovery, those were at greater risk. And those who received intravitreal therapy of 4 or more injections appeared to be at greater risk. The side effects of this drug also appeared to be reduced by using oral probenecid, which inhibits secretion of cidofovir from the ciliary body. So by using probenecid orally, the risk of uveitis and some of the other complications such as nephrotoxicity appeared to be decreased. But ultimately, the mechanism of hypotony and uveitis was really not very well known. The treatment could have been very frustrating because we needed to use topical and periocular corticosteroids in the face of chronic retinitis in those days before we had highly active antiretroviral therapy. So it was quite difficult. And many times the cidofovir had to be continued for saving the life of the patient because they had systemic CMV, but occasionally we had to stop it. And the hypotony was often very prolonged and difficult to treat. We have no effective agents to increase intraocular pressures, and that made the treatment very difficult. The next drug we're going to talk about is rifabutin. So I have a question about rifabutin for you. Rifabutin-associated uveitis can often be confused with which of the following uveitis entities? A, HLA-B27-associated hypopyon uveitis, B, retinal vasculitis, C, necrotizing scleritis, and D, Vogt-Koyanagi-Harada syndrome. Let's see what you guys got. All right, so most of you got it, 42%. So yeah, so the hypopyon anterior uveitis, often unilateral, was a very characteristic finding of rifabutin-induced uveitis. It's a derivative of rifampin. It's an oral antimycobacterial used against MAC complex infection in HIV-positive patients or otherwise immunocompromised patients. And it was characterized by a hypopyon development. The eye looked relatively quiet. It wasn't severely inflamed with fibrin. The hypopyon was a relatively clean-looking hypopyon like you might see in Behçet's, but not quite as mobile as in a Behçet's disease hypopyon. And most of these patients were using a relatively high dose of rifabutin. So this was a dose-dependent response. And when the dose was lowered from 600 milligrams per day to 300, uveitis became much less common, as opposed to nearly 30% of cases when they were at 600 milligrams per day. Usually, the uveitis developed a little bit more than 6 months after initiation of the drug, and there was a re-challenge, induced recurrence, and there was reversibility with drug discontinuation. There are a few cases of other forms of uveitis, panuveitis, retinal vasculitis, intermediate uveitis reported, but by and large, hypopyon uveitis, very common. Here is a picture that Dr. Sen from the NIH had shared kindly with me. And here's another picture of a hypopyon in one of my patients. The hypopyon can be small. Remember, when you're looking for a hypopyon in a uveitis patient, unless you pull down that lower lid, you're going to miss small hypopyons, and sometimes even putting a gonio lens on and looking in the inferior portion of the angle may be necessary, especially when you see a lot of cells in the anterior chamber. 3 to 4 plus inflammatory cells in the anterior chamber often mean that you're going to have some congregation of these cells in the inferior angle and the development of a small hypopyon. So don't miss this. It's embarrassing when you miss a hypopyon that's small just because the eye looked relatively quiet. So dosage and duration of use are important risk factors for rifabutin. And there are other drugs because of the inhibition of cytochrome P450, and we touched on this earlier in drug-induced side effects, but agents such as clarithromycin and ritonavir, which were often given in the early portions of the AIDS era to treat other infections and the HIV disease, appeared to inhibit the cytochrome P450 system and exacerbated the side effects of rifabutin. Intensive topical steroid therapy and reduction of dose appeared to be curative of the inflammation without significant long-term side effects, thankfully. And these patients initially did get laboratory workup, including HLA-B27 and anti-treponema IgG as part of the laboratory workup for the uveitis patient in this setting, and those are negative. And again, that helped establish more clearly the underlying diagnosis of the drug-induced uveitis. Sulfonamides are one of the oldest classes of systemic antibiotics, but they have been associated with a non-granulomatous anterior uveitis, first reported 30 years ago, and often bilateral. And if re-challenged, there was recurrence of inflammation, at least in one report. And so this achieved a fairly high score of causality. The treatment is usually topical corticosteroids or medication discontinuation. A big player in drug-induced uveitis that do not ignore are bisphosphonates. These agents are used very commonly in those, particularly in women who are at higher risk for osteoporosis after menopause. So they're very commonly used and more aggressively used nowadays to prevent osteoporosis and prevent pathologic fractures caused by metastatic malignant disease. They're typically very well tolerated. But let's talk a little bit about what about the characteristics of bisphosphonate-induced uveitis. Is it A, more common with intravenously administered bisphosphonates? B, is it more commonly unilateral? C, is it more commonly a panuveitis? Or D, is it more commonly associated with non-nitrogen containing bisphosphonates? Excuse me. So yes, so more commonly, it's associated with intravenous bisphosphonate use. That is correct. Some of these newer agents, such as Prolia, these are given, zoledronic acid, for example, given IV, and pamidronate given IV, has been associated with a fairly high risk of ocular inflammatory disease. Excuse me, I'm going to take a drink of water here. But all of these agents have been linked to ocular inflammatory disease. It is more commonly bilateral. Scleritis, when it occurs, can be unilateral. Episcleritis and even orbital inflammation has been reported. With intravenous pamidronate, there are more than 40 cases that have been reported in the literature as of 2019, and it's probably a little higher now. And we can see that anterior uveitis is probably the most common manifestation. And usually occurred within 1 to 6 days of infusion. Again, there was a dosage variation, so there wasn't a specific dose dependence here, but there was recurrence with rechallenge of inflammation in most cases. This is a patient who had fairly severe scleritis, as well as he's got a little subconjunctival hemorrhage, unfortunately. I apologize for that, but this is a case of scleritis, significant pain, and she had mild anterior uveitis associated with zoledronic acid. The mechanism is thought to be a release of inflammatory cytokines, specifically from nitrogen-containing bisphosphonates. Nitrogen-containing bisphosphonates are more commonly associated with this inflammatory disease as opposed to the non-nitrogen bisphosphonates. See, nitrogenated bisphosphonates presumably are pro-inflammatory from various mechanisms. They cause significant elevations of C-reactive protein and serum interleukin 1 and 6, and this results in immune dysregulation. And all of this immune dysregulation has been previously reported in other conditions with anterior uveitis. Many of these patients will have a flu-like illness with the infusion and have infusion reactions as well. The therapy is sometimes requiring drug discontinuation or switching to a different agent that does not contain nitrogen. Topical corticosteroids and occasionally oral nonsteroidals can be utilized, and oral corticosteroids in severe cases of scleritis may be needed as well. But usually this is self-limited and the disease recovers once the drug is discontinued on the corticosteroid therapy. Fluoroquinolones have been associated with, I'll put uveitis in quotes here because it's not really a typical uveitis. And it can be bilateral and occur with standard doses of medications, and it can develop within 2 weeks after drug initiation. There can be bilateral ocular pain and visual impairment. I'll say that in uveitis in quotes because there's more pigment disruption in the iris than there is actual inflammatory cell in these patients. We often will see some inflammatory cell when there is this massive disruption of the iris pigment and iris pigment loss. But oral fluoroquinolones have been associated with this, but moxifloxacin has been most commonly implicated. Interestingly, topical moxifloxacin has not been implicated. Intraocular moxifloxacin has been associated with inflammation, but not the kind of changes that we see with the systemic medications. And I'll show you the signs here. But usually fine pigmented KPs are seen. There's prominent pigment in the anterior chamber and minimal non-pigmented cells and diffuse iris transillumination and atonic pupil appearance. And 50% of patients actually developed ocular hypertension, so it could be confused even for herpetic disease. The treatment is usually drug discontinuation, and topical corticosteroids can be helpful early on, but unfortunately the iris damage can be permanent. Here's a picture, a very nice picture from Dr. Sukesh of anterior chamber pigment cells in this reaction. You can see that the almost the small tobacco dust type appearance of the cells or the granules in the anterior chamber fluid. And then you can see this significant loss of pigmentation of the iris. This patient had a brown iris, and you can see these small clumps of pigment granules on the surface of the iris, like freckles, little tiny freckles on the surface of the iris, but that's typical appearance. And look at this on transillumination, the same iris. This is a beautiful slide showing the loss of the posterior and superficial pigment epithelium from the iris, resulting in this atonic pupil with significant transillumination defects. So it's really kind of a pseudo uveitis. It's almost a phototoxicity kind of reaction. And those who have autoimmune predisposition, who have other autoimmune diseases, may be more at risk for this. And these patients may more likely have HLA-B27 or B51 haplotypes. Because this was found in 20 to 40% of patients, 20 and 40% of patients who were tested respectively. So there is some autoimmune association. It has not been described with either topical or intraocular injection of fluoroquinolones. I have seen vitritis from intraocular moxifloxacin injection, and even anterior uveitis occurred. That is following cataract surgery when because some of these proprietary medications like Trimoxy, when there is triamcinolone injected with moxifloxacin, I have seen inflammatory reaction and persistent inflammation following cataract surgery in some patients who received that. Here's another picture of moxifloxacin, systemic moxifloxacin-associated iris transillumination. Next question, I'm going to jump over to TNF-alpha inhibitors. Which of the following TNF-alpha inhibitors associated with uveitis? Infliximab, adalimumab, etanercept, or all of the above? This is a little bit of a trick question. You got it. Excellent. So all of them have been associated with inflammation. So, but etanercept can cause de novo inflammatory disease. These TNF-alpha inhibitors, TNF-alpha is a pro-inflammatory cytokine, and inhibition of this cytokine has been very effective in the treatment of a variety of inflammatory diseases, as you know. And most recently, adalimumab in the last few years has been FDA approved for use of treatment of non-infectious, intermediate, posterior, and pan-uveitis. And all of you are familiar probably with the visual 1, 2, and 3 clinical trial results from AbbVie Pharmaceuticals. But 3 agents fall into this category. There's a 4th agent, but infliximab, adalimumab, and etanercept have been most extensively studied. And etanercept is a soluble TNF receptor conjugated to the FC region of human IgG and is administered subcutaneously. And etanercept inhibits both TNF-alpha and TNF-beta. And whereas infliximab and adalimumab are exclusively monoclonal antibodies that are directed towards TNF-alpha. Adalimumab is fully humanized versus infliximab, which is a chimeric mouse-human monoclonal antibody. And the differences in the mechanism of action of inhibition of TNF-alpha versus TNF-alpha and beta with etanercept may explain the difference in their side effects. As you know, TNF-alpha antagonists have been associated with lupus-like syndromes, demyelinating disease that mimics multiple sclerosis, autoimmune hepatitis, and interstitial lung disease. And uveitis has been associated with as well. Usually, uveitis develops 1 to 12 months after initiating therapy. It resolves after discontinuing the agent. And more than 10% were kind of paradoxical new onset intraocular inflammation after initiating therapy in the case of etanercept. For example, somebody who has rheumatoid arthritis treated with etanercept then develops anterior uveitis. Now, in rheumatoid arthritis, do we see anterior uveitis, as a manifestation of the disease process itself? No. With rheumatoid arthritis, we can see scleritis. Okay, that's the most common immunologic inflammatory disease of the eye. We typically don't see iritis as a manifestation of rheumatoid arthritis, but etanercept, when it's given in RA patients, appear to induce this kind of inflammatory disease. So there was some question about its effect. And the problem is that many of these uveitic cases had required long-term therapy with corticosteroids and other immune suppressive agents besides the TNF-alpha antagonists, because we had to stop those. And there was a relatively poor visual inflammatory control outcome in these cases. All 3 agents have been implicated, however. When you look at the National Database Registry, there have been about nearly 60 cases of drug-induced uveitis associated that have been reported, many more probably unreported, associated with these agents. Most of them are associated with etanercept. There are, however, the second most common is infliximab. That makes sense because infliximab is a murine chimeric antibody versus adalimumab, which is more fully humanized. And there have been de-challenge and re-challenge data for some patients. So the association is fairly strong between these agents and uveitis. So anterior uveitis, periphlebitis, chorioretinitis have all been reported, and a biopsy-proven sarcoid has also been noted to be a kind of a manifestation of this disease. I have seen this with adalimumab, and I've seen it with infliximab, the sarcoid type of inflammatory disease. Again, there's you have to often use systemic corticosteroids in the more severe cases of this kind of drug-induced uveitis to get rid of the inflammation, but there's recovery once you stop the agent. Here's a patient that was with examples of kind of a diffuse granulomatous KPs, and you can see this kind of sarcoid-like perivascular sheathing and these vitreous snowball opacities and preretinal inflammatory opacities in the inferior periphery of the patient who has a sarcoid-like inflammatory response to etanercept. The mechanisms may be related to the inverse relationship between TNF-alpha and interferon, and also interleukin-2, a pro-inflammatory cytokine. If interferon levels are high due to TNF-alpha inhibition, immune cell activation can occur, and autoantibody formation can occur, and immune complex deposition and autoimmune disease occur. And there's a differential risk of uveitis between the various TNF inhibitors, as I mentioned. So etanercept is more likely to cause even de novo inflammation in patients who shouldn't be prone to inflammation, but is more likely associated with uveitis than some of the other agents. Let me kind of move on to the next thing is immune checkpoint inhibitors. And this is a really hot topic today because we're seeing a lot of patients getting cancer chemotherapy with these agents. So most commonly, these agents induce what kind of uveitis? An intermediate uveitis, panuveitis, anterior uveitis, or posterior uveitis? Which is the most common type of anatomic uveitis that is seen with immune checkpoint inhibitors? Yeah, so anterior uveitis, although all of them have been reported, anterior uveitis by far accounts for close to 2/3 of the reported cases of uveitis associated with immune checkpoint inhibitors. Immune checkpoint inhibitors have, they were developed when we realized that tumor cells evade the immune system because they possess specific ligands, the so-called PD-L1 ligand, and a specific CTLA4 receptor, if you will, or antigen that will bind to this CTLA4 that, when bound, inhibits T cell activation. And so by this method, these tumor cells were able to evade the immune system. So when the T cell receptors, the CTLA4 molecule, CD28 molecule, bound to the B7 receptor on the antigen presenting cell, along with the specific major histocompatibility complex on from an antigen presenting cell, when that binding occurs, the T cell was inactivated. Now, in the case of tumor cells, they can do the same thing. They can kind of fake out, if you will, the immune system by blocking the activation of the T cell by actually binding these T cell receptors. So what we do with the inhibition of these, the CTLA4 or the PD-1 or the PD-L1 ligand, by blocking that, we're blocking that interaction. So we're allowing the T cells then to become active. And once they're active, they become natural killer cells or T killer cells and result in significant tumor cell death. And this is how we've been able to kind of modify how we treat metastatic melanoma, metastatic cutaneous melanoma, and other metastatic cancers such as non-small cell lung cancer, et cetera. So these agents are ubiquitously used, and because they tend to prime the immune system, they tend to induce inflammation because they prime the and activated T cells in a broad non-clonal sense, if you will. There are many agents in the immune checkpoint inhibitor category that have been associated with this. So this is a list of them. Ipilimumab, pembrolizumab, and nivolumab are the most commonly utilized. Some of the newer agents, such as cemiplimab, atezolizumab, avelumab, and durvalumab are also newer agents that have been linked also with uveitis with newer reports. There's a very high association of causality between these agents and uveitis. So pembrolizumab results in PD-1 blockade. We talked about the mechanism briefly. You can go back and review my slides later if you wish. I don't want to spend a lot of time here regarding this, but when you bind the PD-1 to the PD-L1, this inhibits the cytotoxic response of the activated T cells. So when we inhibit that binding, we block that interaction, that results in T cell activation, and that results in tumor cell death. The same goes for the CTLA-4 checkpoint molecule that is present on the surface of activated T cells. It negatively regulates T cell proliferation. So ipilimumab inhibits CTLA-4 and upregulates T cell proliferation, and again, used for metastatic cancers. PD-1 blockade is probably the more common mechanism of action among these agents. The ipilimumab is really the main CTLA-4 inhibitor currently available. There's also the PD-L1 ligand, that antibodies that bind to that ligand and inhibit PD-1 interaction that way are also available. And these have also been associated with inflammatory disease, although their inflammatory disease is a little bit more different. It looks like a vasculitic process in the retina as opposed to choroidal or uveal inflammation. There are many immune adverse reactions associated with immune checkpoint inhibitors. Specifically, we know that hypophysitis was originally described as a classic inflammatory response, but pneumonitis and colitis. By far, autoimmune colitis is the most common adverse immunologic event that occurs with immune checkpoint inhibitor therapy. There is a significant kind of a terminology that was developed for adverse event description. And anterior uveitis, there are grades of the severity of this inflammation that you can see here that was developed because of the number of adverse events reported in national database registries and drug registries about these agents over the last approximately 10 years or so. Immune-related events, as I mentioned, they're numerous, but uveitis originally was thought to be about 1% of immune events, but probably it's more like about 2% because it's somewhat underreported. And so far, we have about 94 cases as of the February-March of 2020 of the number of inflammatory events that we see in association with these agents. Probably that number is closer to 100 or 110 at the end of this year. So there's a fair number of cases that have been reported and well documented. Most cases have been caused by those first three agents, the ipilimumab, nivolumab, and pembrolizumab. Some cases have had previous therapy with other agents called BRAF and MEK inhibitors that I'll briefly touch on. And most of these were managed with topical, regional, or systemic corticosteroids. And about 40% required discontinuation of immune checkpoint inhibitor therapy. Remember, these agents are highly effective in tumor control. So we're talking about life and death when we're recommending stopping these agents. So in most of these cases of uveitis, the uveitis was managed independently of the immune checkpoint inhibitor continuation. So 60%, we were able to continue therapy with the immune checkpoint inhibitors because it prolonged the life of the patient. And the quality of life was improved when we treated the uveitis with local and or regional or systemic corticosteroids. You can see here, I've tabulated, this took me a long time to do, but all of the cases, this is a very important piece of information for me. It shows the distribution of the uveitic cases. It's interesting, pembrolizumab, for example, had far more cases of pan-uveitis that were described compared to anterior uveitis. Whereas ipilimumab and nivolumab were mainly anterior uveitis. What's interesting to note is that many of these cases of uveitis in the pan-uveitis case look like Vogt-Koyanagi-Harada syndrome. Why was that? These cases actually were much more common in the metastatic cutaneous melanoma patients that were being treated with immune checkpoint inhibitors. We think the reason for that is because tumor lysis and tumor cell death in melanoma results in release of melanin-associated proteins, which are inherently immunogenic to activated T cells. And as a result, that activation causes those locations of melanin that are normally hidden away from the immune system, if you will, or immunologically segregated, to be exposed then through the choroidal circulation, and that those activated T cells are plentiful enough that they go into the choroid, go into the uveal tract through just the blood flow and natural movement of the cells, and that results in the binding of those T cells to the melanin-associated proteins and induce this VKH-like inflammatory disease process. Most cases developed within 3 months of starting therapy. Most cases were bilateral, almost always, and there was a re-challenge which resulted in recurrence in many cases. Dose response was not possible to determine because these are typically fixed doses, although frequency can be adjusted and more frequent administration of the drugs resulted in more inflammatory reactions. And there were different drugs in the same groups that in the immune checkpoint inhibitors. For example, patients who had reaction to pembrolizumab, if they switched to nivolumab, they got inflammatory disease. At least one patient we had ipilimumab developed anti-uveitis when switched to pembrolizumab. So we know that we have multiple criteria in Naranjo's criteria that meet the definition of definitive causality here. This is a beautiful case of one of the first cases of nivolumab-associated uveitis where the patient developed severe cystoid macular edema. Here's a patient of ipilimumab-associated uveitis that developed orbital inflammation. Developed panuveitis, severe disc edema, and almost a neuroretinitis type picture, and severe choroidal thickening that looked like VKH. Here's one of my patients who developed the multifocal choroiditis, panuveitis type picture. Again, you can see the even vascular inflammation occurring in this agent along with choroidal inflammation. Here's a beautiful report of a VKH syndrome associated with pembrolizumab. This is, you can see a very dramatic appearance that looks clinically exactly like VKH, and this is a bilateral case. So the optic neuropathy has been associated. There's also been associated melanoma-associated retinopathy in patients who treated with melanoma, metastatic cutaneous melanoma, along with immune checkpoint inhibitors. This is much more difficult to parse out and understand because of the association and the nature of how these drugs work and the nature of the metastatic cancer itself. There are other agents, BRAF and MEK inhibitors. These are agents that inhibit the cell cycle and cell proliferation. And these have been utilized in conjunction with some of these immune checkpoint inhibitors. And they have also been associated with inflammation, although less commonly so. Both all of these agents can cause uveitis alone or in combination with PD-1 and CTLA-4 inhibition. There have been cases of uveitis when the agents were used alone as well. So we know that these occur, but they're not quite as, the data is not quite as robust and the cases aren't quite as common. But these are also agents that are used together, and so you need to keep these agents also in mind as causes of inflammation. The treatment is usually, for the uveitis, is usually with topical, periocular, and systemic corticosteroid therapy. You do not need to discontinue immune checkpoint inhibitor therapy in the most cases, unless the uveitis is extremely severe and sight-threatening. There are also other agents, such as erlotinib, which is an epidermal growth factor receptor tyrosine kinase. This has been approved for non-small cell lung cancer. There have been 3 reports of bilateral anterior uveitis. A couple of cases required drug cessation, but these were treated with local corticosteroid therapy. There are many other agents that are less associated with inflammatory disease. Diethylcarbamazine, for example, is a microfilaricidal agent that can induce death of the filaria within the eye, and that in itself can induce a severe Mazzotti's type reaction. So many of these drug-induced uveitis cases are more likely due to the death of microfilaria inducing inflammation rather than the drug itself. Intraocular medications we use commonly in ophthalmology. Anti-VEGF agents have been associated with inflammation, and preserved triamcinolone has been associated with inflammation as well. We don't use preserved triamcinolone intraocularly anymore. There's a black box warning against it. But as far as anti-VEGF agents, Pegatinib, which we don't use very much anymore, of course, it was the first of the anti-VEGF agents. This agent did produce inflammation. It was thought to be related to the preparation of the drug. We don't use it. It's kind of more of a historical interest. Ranibizumab, of course, Lucentis, is very commonly used for the treatment of diabetic retinopathy as well as neovascular macular degeneration. And this has been associated with inflammation in about 2% of treated eyes in the Marina and Anchor trials. But uveitis appeared to be more common in some of the other studies, but these were a little less well controlled and fewer patients involved. Bevacizumab has also been associated with inflammation, although less commonly so, in about a little less than 1% of patients. So we think that it's about 0.5%. Most of these are generally anterior segment inflammation with mild spillover vitritis, but occasionally they can be quite severe. They can be fibrin and hypopyon. It can look like a sterile endophthalmitis. In these cases, when we see inflammation like this develop after intraocular infection, we have to think about the possibility that this could be infectious. So especially if there's fibrin and there's a hypopyon, I tend to treat these patients as an infectious endophthalmitis following intraocular injection if they develop this kind of reaction, rather than a sterile inflammatory process. But it's a clinical impression that you have to have. If the patient got the injection and within 3 days presents with pain and vision loss, likely that's an endophthalmitis. If the patient presents 2 or 3 weeks after an injection with anterior chamber inflammation, mild corneal edema, in those cases, I'm going to be more likely to think about the possibility that the drug is actually producing an immunologic reaction because the patient has autoantibodies or antibodies directed towards that specific drug. Again, anti-VEGF agent induced inflammation is relatively uncommon, but because we do so many injections now, millions of injections being done around the globe, we're going to see these cases. You need to keep these in mind. Often we have to discontinue the agent or switch to a different anti-VEGF agents, and we often treat these just with topical corticosteroids or cycloplegics. I'm going to move on and talk a little bit about an important agent that has had received a lot of press recently. That's brolucizumab. Brolucizumab-associated uveitis causes visual loss through which mechanism? A, occlusive retinal vasculitis, B, cystoid macular edema, C, exudative retinal detachment, or D, uveitic glaucoma. Okay, so occlusive vasculitis was the most commonly reported or the thing that was causing significant amount of vision loss in patients was occlusive vasculitis. That was present even in the milder cases when wide field angiography was performed. Brolucizumab is a single chain antibody, the newest of the anti-VEGF agents. It has a very small molecular weight and appeared to, in the Hawk and Harrier trials for neovascular macular degeneration, have significant efficacy and better than non-inferiority in terms of its effect, and non-inferiority when used every 8 weeks after the initial first 3 monthly injections. Beovu, or brolucizumab, has been associated with significant uveitis and uveitis-related complications, the most severe of which was occlusive retinal vasculitis and severe vision loss. We think that the inflammation, the incidence is probably, or prevalence is probably closer to about 3 to 4%, as opposed to 1%, because the reports appear to be increasing as more of the drug is being used. The inflammation can be treated and managed with topical agents, but or systemic corticosteroids. But when occlusive retinal vasculitis and choroidal vasculitis occur, unfortunately, in those cases, the vision loss can be permanent. And there have been patients with profound vision loss associated with this. One case of bilateral profound vision loss in a patient that's received bilateral injections on the same day. It's a very, very important thing to kind of keep in mind. The morphology appears to be mainly anterior uveitis, but look, posterior uveitis and the combinations were not uncommon. If you look at the totals, retinal vasculitis was reported in 85% and occlusive vasculitis. So you have to really look for it with wide field angiography when you see inflammation following brolucizumab. It can be quite severe and extend into the posterior segment like this and result in profound vision loss. Even with an inactive neovascular lesion here that you see in the bottom right on the OCT, you can see the dramatic vascular occlusive nature of this reaction. Here's another severe vaso-occlusive, and this involves the choroidal vasculature as well as the retinal vasculature, a profound vision loss in this patient. The visual outcomes can be quite severe with 6 to 7 lines of visual loss when you have occlusive vasculitis with this drug. So I have been very cautious in its use. I still have a few patients that are tolerating the drug well. And I think the key to this, at least in my personal humble opinion, is that you have to be very careful of the dosing. You do not want to give any more than 0.05 cc's of the drug. I think that the amount of drug and there may be a dose-related response. It's not been proven, but I think that may be an issue here. There have been re-challenge data too, and I have seen someone referred to me with who was re-challenged multiple times with brolucizumab, who developed fairly severe inflammation with repeated re-injections. Triamcinolone acetonide, when it was preserved and we injected in the eye, produced inflammation, but it's kind of sometimes inflammation can be a sterile endophthalmitis like this, and was treated and improved with intensive topical corticosteroids and or periocular corticosteroids. But infectious endophthalmitis was suspected and empirically treated based on whether or not there was pain and severe vision loss in some of these cases. But it probably was a toxic reaction to the drug and possibly to the vehicle, especially when we had preservatives. Now with preservative-free formulations such as triesins, we are not seeing that as much. Sometimes we saw pseudoendophthalmitis in pseudophakic patients or aphakic patients with a drug deposited in the anterior chamber. When that's different, that did not need to be treated. It went away just with repositioning of the patient. Here's a patient who had triamcinolone particles in the APC that you can see. I will spend a little bit of time on drug-induced topical medications, and I think we're running very late. I apologize, but this is a very important topic that I thought that I would share. And if you want me to finish the rest of it, I can try to go more quickly. I know that we're getting late. Let me know. Lawrence, you can chime in and let me know if I need to stop and answer questions. But I'll spend a few more minutes on topical medications before we kind of just briefly end on vaccine-induced inflammation. Metoprolol is not very often used anymore. It's a non-selective topical beta blocker for the treatment of glaucoma. It was associated with granulomatous anterior uveitis. Firm data, very strong data in association. Drug discontinuation, topical steroids were the key to treatment, but mechanism remains unknown. I'm going to skip the next one. Brimonidine is a very important one. We use this very commonly, but this can be associated with granulomatous anterior uveitis associated with IOP elevation, and often these patients had follicular conjunctivitis associated with brimonidine use. This follicular reaction is almost universal along with this granulomatous anterior uveitis when you did see the uveitis to help you in making the diagnosis. Here's a patient of mine that had bilateral brimonidine-induced inflammation. We stopped the drug and put the patient on a topical, very weak topical steroid, and the inflammation went away within a couple of weeks. And this patient also had severe conjunctival follicular reaction to the drug and had chronic red eyes as well. So many of these patients will have this kind of presentation with brimonidine. So brimonidine is an important cause of granulomatous anterior uveitis that you need to keep in mind. Latanoprost, tavoprost, and bimatoprost have been associated with changes in iris color, conjunctival hyperemia, growth of eyelashes, which we all know about. It can exacerbate underlying cystoid macular edema, and occasionally we saw anterior uveitis and even reactivation of herpes simplex viral keratitis with these agents. They do cause breakdown of blood aqueous barriers, and they are specifically designed, in terms of preventing, and inhibiting or acting like prostaglandins, but low concentrations are specifically designed to address this side effect to avoid kind of excessive inflammatory response. But even with this, we do see mild amounts of anterior uveitis with this drug. Many people have asked me about use of prostaglandins in uveitis patients, and uveitic glaucoma. You know, as long as you have topical corticosteroid therapy, I don't think that prostaglandins are necessarily a contraindication in patients who have chronic uveitis or uveitis associated with glaucoma. You know, the concomitant use of some topical steroids along with the prostaglandin analogs often mitigates any prostaglandin analog associated inflammation. So they're not a contraindication for the treatment of uveitic glaucoma. Drug discontinuation, if you saw significant inflammation or CME, may be considered, and you might want to use other anti-glaucoma medications, and topical steroids and nonsteroidals may be useful as an adjunctive treatment to the drug-associated inflammation. Again, this is probably resulting from you know, pro-inflammatory effects of the prostaglandin analogs and increased production of IL-1 and IL-6, which appear to be present in the tear film of these patients who are using these medications, and that probably results in anterior chamber inflammation. I'll skip the podophyllin. This is just capsaicin. These are just interesting sidelights. These have been reported with anterior uveitis. There's modest data to suggest that there may be an association here. Vaccines have been associated with uveitis. I want to ask you a question. Which of the following statements is true regarding vaccine-associated uveitis? A, it often results in irreversible vision loss. B, it is recalcitrant to usual treatment modalities. C, it is so common that vaccination should be abandoned. Or D, it is often mild and self-limited. And this is the main takeaway point that I want to talk about with vaccine-associated inflammation. And yes, exactly. It's all, so vaccines by far are far more beneficial than any associated side effects. These side effects that we see are more curiosities. Fortunately, in the vast majority of these are mild and self-limited. You're exactly right. So you guys already know this lecture. But we've talked about this in a couple of recent editorials about the value of vaccines. Billions of vaccines are given around the globe, and only a handful of cases have been reported. So if you look at the total number of vaccine-associated uveitis reports, about 300 cases have been reported so far through multiple database registries that we have. The most important database registry, I want to give a shout out to Dr. Fraunfelder, who started this many years ago, the National Registry of Drug-Induced Ocular Side Effects in Portland, Oregon. You know, you can see that the hepatitis B vaccine is the one that's been most commonly associated, followed by the HPV vaccine, which was more recently introduced, followed by the influenza vaccine, which is given more commonly, and the BCG inoculation of vaccination that's given in certain parts of the world has also been associated. Other ones that are less commonly associated, more commonly occurs in these vaccine-associated uveitis cases more commonly in women and appear to be in younger patients, and usually occur within a couple of weeks of the vaccination, but can occur as late as 2 or 3 months after vaccine. The mechanisms remain unclear, but there may be molecular mimicry, antigen cells, specific cell and antibody-mediated hypersensitivity reaction, and there may be a couple of other mechanisms, such as the adjuvants-induced inflammation, because adjuvants are an important part of certain types of vaccines, and though more relevant to the inactivated or subunit conjugated vaccines containing only components or parts of the pathogen, where you have an adjuvant where the adjuvant's actually inducing the inflammation. There's a generalized kind of autoimmune inflammatory syndrome called the Schoenfeld syndrome that is associated with adjuvants, or the Asia syndrome. And this is a post-vaccination phenomenon. It's been shown to be probably the underlying pathogenesis for macrophage myofasciitis syndrome, a very rare syndrome, the Gulf War syndrome, silconosis. So many of these patients have an underlying family history of autoimmune disease, and they're more at risk for developing these kinds of inflammatory reactions. Adjuvants that are commonly used include aluminum salts, silicone, and other infectious agents, especially if somebody has had previous exposure to antigens, that may prime the immune system and may make it more likely that they're going to get inflammation. So I won't bore you with BCG vaccine. This has been used intravesically for the treatment of bladder cancer, as well as prophylaxis for Mycobacterium tuberculosis in certain areas of the world. It can cause bilateral granulomatous or non-granulomatous inflammation. It responds to topical steroids. There are rare cases of VKH-like syndrome associated with this. hepatitis B vaccine, even though there are very commonly reported cases, there's not enough robust information because rechallenge data is limited and the causation has not been clearly established. Same with influenza vaccine. Interestingly, recently I have seen influenza vaccine patients associated with AMPI and with MUDES. I have a couple of very interesting cases of that. Varicella zoster vaccine, this is a kind of a controversial area. The Shingrix vaccine is an antigenic vaccine, has been replaced by a new Zostavax vaccine. And both of these had been associated with inflammatory, systemic inflammatory reactions, as well as local ocular inflammatory reactions that have been varied. There's also been some report of de novo development of necrotizing herpetic retinitis associated with some of these things. So it is a little bit of a dicey area when people, as a uveitis specialist, people come and ask me, hey, should I get the zoster vaccine? I usually tell them the Zostavax is safe and it's highly unlikely that they're going to get a problem from this. You know, the ARN patients did do okay, but they have a poor visual prognosis, and can be a devastating illness, obviously. But I don't think that if those cases are so rare, I don't think it's a reason to avoid them. Even yellow fever vaccine has been associated with uveitis reports. But, you know, I wanted to kind of just wrap things up and say that, you know, drug interactions that we use in ophthalmology are common, and dose adjustments may be necessary. You need to make sure that you don't use corticosteroids with nonsteroidals. And then number two, drugs must be considered as an etiology in the evaluation of uveitis patients as the cause of the inflammation. You do this through a thorough history and physical examination and laboratory testing, but a history and physical examination may help you in delineating the cause of the inflammation without having to do expensive laboratory tests. But when you're not sure, laboratory testing is part of the laboratory workup, part of the workup of this patient. And often these types of inflammatory diseases can be cured because you remove the offending agent and institute corticosteroids and they get better. I appreciate your attention. I'm going to see if I can answer some questions. I'm sorry that I went over. I knew it would be a long lecture. I'm going to start with see if I can answer the questions here quickly. Can long-term topical moxifloxacin also cause iris changes and uveitis? Typically, we find that it's an idiosyncratic response. I don't know that long-term there's any data to suggest that long-term moxifloxacin, topical moxifloxacin absolutely has not been associated with any kinds of iris changes that we are aware of based on reports, Dr. Pandey. The next question is, in your experience, can vaccines, for instance, measles, mumps, and rubella induce inflammatory reactions? I just showed you that it can. There have been reports of that. MMR vaccine has been associated with that. And so the treatment is corticosteroids. Sometimes systemic corticosteroids may be necessary. How do you diagnose uveitis with a history if you have no slit lamp? Very difficult, almost impossible. So a slit lamp exam, and I know many of you consult with me on the uveitis. So when you send me information, I really can't say, because chronic uveitis, remember, doesn't cause any symptoms. And so you may have a lot of inflammation and chronic changes structurally in the eye, but you can't see it unless you look at them under the slit lamp with a microscope, okay? And you have to dilate their pupil and look in the back of the eye. And so you need a really good slit lamp in order to do a thorough ophthalmic examination. So uveitis can't, so that's why I can't do telemedicine in this COVID era. You know, we can't make a diagnosis. Even acute anterior uveitis, unless you look at the slit lamp and see cells in the anterior chamber, you can't make that diagnosis just because the eye is red and they're photophobic, okay? So, you know, wear an N95 mask, have the patient wear a mask, and limit your exposure. But unfortunately, you have to look at them at the slit lamp to make the diagnosis. With a normal torchlight, can we see cell and the tell condition of the iris? Very, you know, unfortunately, you're not going to be able to tell unless the patient has very severe chronic disease and has posterior synechia and the pupil doesn't dilate. You're not going to be able to tell whether there's anterior chamber cell or flare. You need a slit lamp. You need a slit lamp in order to examine the patient for uveitis. In your experience, can a vaccine such as MMR-induced neuroretinitis? I think yes, our patient developed JIA. First symptom was decreased vision. Parents suggest it was after vaccination. You know, that is this is where you, as a specialist, then need to kind of sort out what came first, the chicken or the egg. Vaccinations for MMR are very common. Uveitis induced from that is very uncommon. And then you have JIA, which is probably more common than the vaccine-associated inflammatory disease processes, okay? So there are specific types of inflammatory changes that have occurred from vaccines, but these reports are very narrow, very small numbers, whereas we have lots of information about chronic anterior uveitis that occurs in JIA, particularly postearticular JIA. So history, physical, and then if the patient is, if the young girl with inflammation in both eyes that's chronic and asymptomatic at presentation, then you know that it's more likely going to be JIA-associated inflammatory disease as opposed to the vaccination. And being vaccinated as a child against mumps, measles, and rubella is going to save her life, okay? So the JIA is most likely the cause of the inflammation. What is the difference between infectious endophthalmitis and immune endophthalmitis and So, this is an excellent point. So infectious endophthalmitis, as I mentioned, in my experience, presents more than 2 or more days, after an intravitreal anti-VEGF injection and is associated with pain and severe vision loss. And those patients, and they often have fibrin and a hypopyon in the anterior chamber. Those patients need to have a vitrectomy or a vitreous tap, an injection of intravitreal antibiotics, and that's how you make that diagnosis. Now, if the patient presents with milder inflammation that occurs, weeks, 2 weeks, 2 to 3 weeks after an intravitreal anti-VEGF injection, that is an inflammatory reaction, okay? That is more likely not an endophthalmitis. However, you have to use your clinical, gestalt to make the diagnosis. And again, if you suspect endophthalmitis, you're much better off to tap and inject that patient than to leave that patient alone and not treat it, because then you have irreversible vision loss. How to differentiate sterile endophthalmitis? Okay, so the next one is, does brimonidine cause intraocular pressure to be elevated? So brimonidine-associated inflammation, when it occurs, when the granulomatous uveitis, almost always is associated with elevated intraocular pressure and almost always has concomitant follicular conjunctivitis associated with it, okay? So pilocarpine causes inflammation too. Yes, it can. I didn't cover that, but pilocarpine also has a pro-inflammatory effect. It can exacerbate inflammation, so we typically avoided pilocarpine in uveitis patients. And it can also have profoundly negative effects on uveoscleral outflow, so we tended to avoid it in patients who have chronic uveitis anyway. But I have seen a breakdown of blood aqueous barrier and increased cell and flare in patients on pilocarpine occasionally. Can moxifloxacin induce BADI and BAIT? I'm not sure what those, I'm sorry, I'm not sure what those acronyms stand for. I apologize. Can COVID infection result in irreversible visual loss or amaurosis, and how? Okay, so COVID infection, in my experience, it causes visual loss mainly through chronic ventilator-induced keratopathy. The patient is face down on a ventilator for 2 weeks or more without appropriate corneal protection, and they can get severe keratopathy. That's the most common cause of vision loss. And I have had several patients who have had that over the course of the last 7 months. Now, the other things that are not reported are in the vasculitic nature. So there have been reports of post-COVID associated vasculitic changes, immune vasculitis changes, specifically involving the coronary arteries in children. And there may be a vasculitic condition affecting the cerebral vasculature as well in patients who have had COVID. I am not an expert in this area, so I have to, but I have not seen it affect the retina specifically. I have one patient who has COVID-induced uveitis, I think, and she had perivascular inflammation, which is probably commonly associated with those RNA viruses, but I cannot prove it because no lab was willing to do aqueous sample evaluation for the COVID-19 virus because they had no standardization of that PCR assay, of the reverse transcriptase PCR assay. You had a slide that listed topical steroids as possible causation. However, this is often used as treatment. Can you clarify? Yes. So Vasudha, I think that the issue here is that there was in the 1960s a very couple of reports of African American patients who received topical corticosteroids who then got inflammation on topical corticosteroids. But the reports were muddled. The reports were muddled by the fact that many of those patients were found later to have syphilis and syphilitic uveitis. So editorially, I had to include that in one of the papers that I wrote about 25 years ago, but I had some concerns about including that slide. So the causation is kind of moderate, but some people who originally used the formulations of corticosteroids that were made in the 1960s also thought that vehicular induced inflammatory disease may have played a role. I don't know, and I have not seen anything like it with modern topical corticosteroids, so I wouldn't worry about that. So that's my clarification. Do COVID-19 vaccines have any uveitic side effects? I have not seen the released data because I don't know that data will be released yet from the phase 3 clinical studies from the 3 companies that have currently usable vaccines in phase 3 clinical trials, Pfizer, Moderna, et cetera. I have not seen their data. I suspect that there may be some reports, but again, we have so many patients affected that the vast, I can't emphasize this enough, vaccinations have provided more for this world than any side effects that they've induced. Okay, so it is incredibly essential that we get on board with COVID-19 vaccines so we can get our lives back to normal. How do you treat recurrent CMV anterior uveitis? CMV anterior uveitis was described originally in Singapore and in the Far East with anterior chamber paracentesis. It is there has 2 presentations. One is an acute hypertensive uveitis that mimics the old Posner-Schlossman syndrome. And there's another one that mimics the more chronic Fuchs uveitic syndrome type appearance. The treatment is difficult. Topical Zergan gel can be utilized in some cases. Oral valacyclovir can be utilized, but it is very expensive and extremely myelosuppressive and cytotoxic. So it is a difficult inflammatory disease to treat. Most patients respond to low doses of topical steroids alone. So I often manage them with that, and occasionally when they flare up with topical Zergan. Oral acyclovir and oral valacyclovir probably are not as helpful as valganciclovir. If I've said valacyclovir, I meant valganciclovir. So oral valganciclovir is cytotoxic and myelosuppressive, profoundly so, and it has to be used very carefully. Vancomycin intraocularly has been associated with a hemorrhagic occlusive retinal vasculitis. It is a dose-dependent response. It is more of a direct drug toxicity than it is an immunologic phenomenon because it occurs immediately after drug installation in the eye. So intravitreal injection of vancomycin should be done very carefully, and 1 milligram in 0.1 cc is the maximum tolerable dose and concentration of drug. Does topical corticosteroid cause uveitis? Yeah, I think I've already, modern corticosteroids don't. So bottom line is I wouldn't worry about that slide. What is your approach treating vaccine-associated uveitis, and what kind of uveitis to expect? Again, anterior uveitis is the most common, and typically I would use topical or regional corticosteroids. They tend to be self-limited, improve very quickly. The next question, even intracranial adrenaline also causes. There are many things, when you inject things in the eye, that can cause cell and flare. Remember that when you inject something in the eye, you're violating the blood aqueous barrier immediately. even that can cause a few cells to come into the anterior chamber. So there are many, and this is a direct mechanism with intraocular adrenaline. So how long after vaccination should we see uveitic changes? Typically 2 or more weeks afterwards. And then finally, how you treat recurrent CMV you already told, a topical antivirus or econopred. I already mentioned with topical antivirals, yes, topical Zergan gel, which is a topical ganciclovir gel, and topical prednisolone or FML drops can be useful, yes. In advanced glaucoma treated with the brimonidine and can cause, how do I, so there is a question about a glaucoma and uveitis. Well, in advanced glaucoma, you're going to have to stop the drug and see how the inflammation responds and use a very low, topical steroid that will not cause pressure elevation, such as lotoprednol, Lotamax, or perhaps FML fluorometholone may be utilized. So somebody has pro-vaccines, but our patient is sibling and parents are not quite sure if they should vaccinate or not the other child. You know, I think you have to have they should talk to the pediatrician and talk to you and come up with a consensus decision. I wish I could predict the future and give them a crystal ball as you can, Christina, but I don't know the answer to that question. I suspect that the value of a vaccine is far greater than the potential risk, that it will have some immunologic side effects. For immune endophthalmitis, do you still do an anterior chamber tap? Well, if it's immune and you think it's non-infectious, I would follow them closely, put them on incentive topical steroids, and see them daily until you see where they're going. If you think it's non-infectious, so I would use topical prednisolone or Durezol very frequently, like every hour or every 2 hours, and monitor them closely to see what they do. How long to discontinue the uveitis for disappearing brimonidine? Brimonidine, I have to keep them off for about a month before the inflammation goes away. For uveitis associated with CME, we use anti-VEGF. So if the patient develops uveitis due to anti-VEGF, how can we differentiate between primary uveitis and the patient had? So uveitis, usually with anti-VEGF therapy, in cases where I'm using anti-VEGF for the treatment of CME in uveitic cases, number one, I typically don't, okay? I don't do that. Number two, I think that if you use anti-VEGF therapy, often the CME is recalcitrant, whereas the inflammation is well controlled. So if you have well controlled, no anterior chamber cell and no significant vitreous cell, and you have CME, and then you give an anti-VEGF agent, and then subsequently 2 weeks later they develop inflammation, that might give you a clue. These are clinical questions that are very difficult to parse out sometimes. So you're asking a very good question that I don't think there's a definitive answer to. So I think the best thing is, if you suspect it, avoid the drug and see if you can manage it in different ways, manage the CME and the uveitis in the traditional methods. Can primary acute middle maculopathy be linked to COVID? Or paracentral acute middle maculopathy, excuse me. I think in this situation, yeah, I don't know. I think that you can certainly see vasculitic, secondary vasculitic changes related to this, but to post-COVID syndrome. So I think it's possible. The reports have not come out. There have been cases of cotton wool spots and other type of vascular changes that occur in COVID infection. The Brazilian group has reported the probably most extensively in hospitalized patients having retinal evaluation, who did show that they developed cotton wool spots and PAM-like lesions. So I know that's been reported. Okay. What is the best treatment for anti-uveitis in children? Chronic anti-uveitis, immunosuppressive therapy, topical corticosteroids, and the help of a pediatric rheumatologist. Without going into greater detail, that's a big question. To what extent do laboratory testing in uveitis what do you use aqueous and vitreous humor testing? Okay, yes, the answer to laboratory testing, drug-induced uveitis is a diagnosis of exclusion. History and physical examination and a detailed drug history for the patient will tell you the answer most of the time, okay? However, in cases where you can't sort it out, a laboratory evaluation should include the ability to rule out 3 important causes of inflammation. 1, tuberculosis, 2, syphilis, and 3, sarcoidosis. Those are the most common causes of uveitis that we need to rule out. So I would check for those things. So you get a treponemal specific test, such as anti-treponemal IgG. You would do a quantiferon TB or PPD skin test, and then you would do a chest X-ray and serologic testing for sarcoid that you like, along with serum calcium. Those can be helpful to you to evaluate. If you think that the patient has unilateral hypertensive uveitis with corneal changes and you think it's herpetic disease, then I would do an anterior chamber paracentesis with PCR, vitreous testing, vitreous cytology testing, and vitreous sampling for PCR should be reserved for viral retinitis, toxoplasmosis, and other conditions where you don't have a definitive diagnosis and the patient is worsening on traditional therapy. Can topical steroids and NSAIDs for eye treatment associated with steroid cause uveitis? Can topical treatment with NSAIDs for eye treatment associated with, not in my experience. I think NSAIDs can cause significant corneal, topical NSAIDs can cause significant corneal toxicity. I have seen that, but not anterior uveitis. Can topical cyclosporine be used for drug-induced uveitis? I have no experience with it. Topical cyclosporine comes usually in an oil emulsion. In topical restasis, for example, 2% topical cyclosporine solution. I have very little experience with it. It tends to be quite irritating to the ocular surface when it's in higher concentrations. I don't know that it has any great benefit in the treatment of anterior uveitis. Combining topical treatment for eye pathology. I'm sorry, I don't know what I forgot the previous question about combining. Moxifloxacin is using as one of the COVID treatments in pulmonary infections. What does it mean, long-time use of moxifloxacin, more than a week? I use moxifloxacin orally for a couple of weeks in some patients for infectious conditions for 2 weeks, 3 weeks. I think it is okay, but when it's combined with corticosteroids, it may increase the risk of tendon rupture. It can also be associated with that ocular response with pigment loss that I told you about. It's just something they need to be monitored for. Those responses, Dr. Tandili, are pretty uncommon, but I think just monitoring, making the patients aware. Which drugs can cause acute angle closure like anterior uveitis? Well, the classic ones that have been associated are the anti-migraine medications. I'm blanking on it. I didn't talk about this. Medications is an excellent point here. But there are a couple of drugs that have been associated with forward rotation of the ciliary body, choroidal effusions, and angle closure. I'm sorry, you caught me off guard. It's a migraine drug. I can't believe I'm not remembering it. I'll have to get back to you on that. I'm sorry. I'm embarrassed. I should know this because I always ask the patient about this drug and I'm blanking on the name. But anyway, I appreciate all your, topiramate. Thank you, Vijaya. I appreciate it. Topiramate is the drug. Topamax, we call it Topamax here, but topiramate. Thank you so much. So you guys are extremely good. Thank you so much for your participation. It's a real pleasure. I really enjoyed this. I hope that you learned a little bit, and I know I learned that I shouldn't forget topiramate. So have a great week. I hope you all stay safe and healthy, and have a good day and good evening. Bye bye.